Good morning, good morning, good morning. This is Dr. Ryan here. Thank you once more for joining me. Once a friend asked me to tell him a potassium joke, and I said, okay, hey, be nice, man. Okay, let me tell another joke to redeem myself. Have you heard that once oxygen and potassium went on a date, it went okay? Thank you. That's better. So once again, thank you for joining me on another high-impact algorithm in internal medicine. This one is our fourth in nephrology and our 17th overall. So we're covering good ground here. I hope you guys enjoyed the last algorithm on acid-base disorders. Today we're going to move into the domain of electrolyte disturbances, discussing the topic of hyperkalemia. So a quick one on potassium. Potassium homeostasis is regulated by the balance between exogenous intake, excretion in urine and stool, and transcellular shift. So transcellular shift of potassium occurs rapidly and is primarily driven by insulin and catecholamines. Maintenance of normal serum potassium levels is important for a variety of reasons, including stability of heart and other muscles. Of course, we know it maintains nerve and tissue excitability, right, together with sodium. Hyperkalemia is generally defined as a serum potassium of above 5 milliequivalents per liter. Clinical manifestations of hyperkalemia include weakness, paresthesia, palpitations, ECG changes, and dysrhythmia. The kidney is the principal organ responsible for regulating total body potassium. Hyperkalemia can be caused by, as we see, renal or extrarenal processes. Renal causes of hyperkalemia can be separated according to renal function. In patients with impaired renal function, the risk of hyperkalemia is generally higher with AKI, which is acute kidney injury, as adaptive mechanisms occur in the setting of chronic kidney disease to maintain potassium homeostasis. Extrarenal causes of hyperkalemia are primarily related to transcellular shift. The etiologies of hyperkalemia in the setting of a normal renal function also occur in the setting of renal dysfunction, generally with more severe results. Management of hyperkalemia depends on its severity and rate of development. IV calcium can be used to stabilize the myocytes in hyperkalemic patients. Pharmacological agents can be used to promote the influx of potassium back into cells, example, salbutamol, and to increase potassium excretion in the urine, example, furosemide, and stool, example, sodium polystyrene sulfate. Renal replacement therapy may ultimately be necessary to treat hyperkalemia, particularly in severe cases. So I hope you're hungry because we're going to sink our teeth into this one. On the left, we have renal etiologies, of which there's 6. On the right, extrarenal etiology 7, giving us hyperkalemia with 13 etiologies. Renal is divided into that which causes decreased clearance and that associated with normal clearance. That which is associated with decreased clearance is increased oral potassium intake. If you're giving the patient, obviously, an IV potassium infusion, or if the patient is constipated. In the setting of normal clearance, medication that can cause hyperkalemia, example, your ACE inhibitors, yes indeed. Hypoaldosteronism, which is otherwise called, Addison's, and pseudohypoaldosteronism. Then in terms of extrarenal etiologies behind hyperkalemia, includes mechanisms of transcellular shift. Example medications, once again, ACE inhibition, beta blockers, acidemia. Because remember we said in our previous algorithm that alkalosis is associated with hypokalemia. So acidemia is associated with hyperkalemia. Hyperosmolality, rhabdomyolysis, tumor-lysis syndrome, where there's basically lysing of cells, liberating potassium into the bloodstream. Insulin deficiency, because remember that insulin is the key that unlocks the door for glucose to enter into the cells and for potassium to also enter the cells. So often in DKA, before you treat it, the patients often present with hyperkalemia. And as you give the insulin to shift the glucose into the cells, the potassium enters the cells. And so we know that insulin deficiency is associated with hyperkalemia. And also in this instance, it's interesting, why do you give the patient dextrose later on? Because obviously you don't want the patient to be neuroglycopenic for the rest of their lives, right? And the other one is hyperkalemic periodic paralysis, right? Giving you a whopping, once again, 7 extrarenal etiologies, 6 renal, giving you 13 etiologies behind hyperkalemia. So it's motivational scripture time. So, a dream, and I'm sure lots of us have dreams in life, a dream written down with a date becomes a goal. A goal broken down into steps becomes a plan. And a plan backed by action becomes reality. Proverbs chapter 19 and verse 21 says, "Many are the plans within the heart of a man, but it was the Lord who directs his steps. It is the Lord's purpose and plan that prevails." So whatever you want to achieve in life, be consistent at it. Plan beforehand and commit your way to God, and you will succeed. Hope that this has been encouraging and helpful for you. Tomorrow, of course, as predicted, we're going to be talking about hypokalemia. I'll see you then. Have a great day.